we are today going to discuss on rational use of antimicrobials and antibiotic stewardship program. Now, by what do we mean by rational use of antimicrobials? As we know, rational use of medicine means basically right drug given to the right patient in right dose, duration and frequency. So basically, learning objectives, we are going to discuss, define rational use of antimicrobials and factors affecting it, WHO aware classification of antibiotics, antibiotic stewardship program and applying the principles clinically. Now, rational use of medicines that include right drug given to right patient in right dose, duration and frequency. Now, what's the problem with irrational use of antimicrobials? That lead to basically heavy cost burden, antimicrobial resistance and significant adverse effect. Hence, rational use of antimicrobials should be strengthened. Now, choice of antimicrobials for the infection should depend on the three broad factors: on the patient factors, on the drug factors and on the organism related factors. Now, among the patient factors, age, local factors, host defense, allergy, pregnancy, hepatic and renal function and genetic. Coming to the age, chloramphenicol is generally not administered in the newborn, premature infant, lactating mother or pregnant mother during labor. Why? Because when administered to them, chloramphenicol may cause grey baby syndrome in the newborn or the premature infant. How? Basically, in the newborn and premature infant, the hepatic metabolism is not matured and the renal elimination system is not matured. As a result, the chloramphenicol metabolites get accumulated in the body, leading to toxicity, causing ashen grey discoloration of skin, leading to grey baby syndrome. Similarly, sulfonamides are avoided in newborn and premature infant because they can lead to kernicterus. These sulfonamides basically displace unconjugated bilirubin from the protein binding site, causing rise in unconjugated hyperbilirubinemia. Now, in the newborn and in the premature infant, blood-brain barrier is weak. As a result, these unconjugated bilirubin, they cross blood-brain barrier in them, causing permanent brain damage, leading to kernicterus. In elderly, aminoglycosides are more prone to cause ototoxicity and nephrotoxicity. Tetracyclines causes teeth and bone malformation in children. Now, coming to the local factors, presence of pus. Basically, in presence of pus, many antibiotic efficacy decreased because they cannot penetrate the abscess cavity, like sulfonamides, particularly aminoglycosides. Even abscess create anaerobic environment, and when the abscess is drained because of the entry or exposure to oxygen, anaerobic bacteria basically are subsided. pH, acidic pH prevents the decrease the efficacy of the aminoglycosides and macrolides. Now, presence of necrotic tissue, implant, or the indwelling catheter, they cause proliferation of bacteria, and the addition of bacteria result in the formation of biofilm, so that these bacteria continue to proliferate along the surface. Now, this biofilm, they prevent the antibiotic to act, so that the efficacy of antimicrobial is reduced. Hematoma again favors bacterial growth. Penicillin and cephalosporin are effective in them. Coming to the host defense, if the patient is immunocompromised, then more potent antimicrobial should be used for longer duration and at higher dose. Again, in immunocompromised patient, bactericidal drugs are preferred over bacteriostatic drugs. And as the patient is immunocompromised, the organism may not be eradicated, leading to the relapse. Allergy, when a person is allergic to some antibiotic, it should not be used in them. Like a patient suffering from syphilis, if the drug of choice here is penicillin. If the patient is allergic to penicillin, we prefer erythromycin. Pregnancy. In pregnancy, among the antimicrobials, penicillins, cephalosporins, erythromycin, these are considered safe. The other antimicrobials are teratogenic and causes risk to the fetus or the baby, fetus. Tetracyclines may affect fetal teeth and bone. The drugs that should be avoided during pregnancy are sulfonamides, cotrimoxazole, chloramphenicol, fluoroquinolones and nitrofurantoin. Coming to liver and kidney disease, as most of the metabolites are, most of the antimicrobials are metabolized in liver and eliminated via kidney. So many antibiotics cannot be used in liver disease or kidney disease. So impairment of kidney and liver function causes toxicity. Antimicrobials avoided in liver dysfunction, nalidixic acid, nitrofurantoin, tetracycline except doxycycline, pyrazinamide, erythromycin and pfloxacin. Antimicrobial dose has to be reduced in renal failure, that include nalidixic acid, tetracyclines, pyrazinamide, nitrofurantoin, aminoglycosides, cephalosporin, flucytosine, vancomycin, ethambutol, imipenem and meropenem. Drugs that are not eliminated by kidney and can be used in renal failure: doxycycline, rifampicin, erythromycin, ceftriaxone, cefoperazone and chloramphenicol. Coming to the genetic factor, certain drugs cause hemolysis in G6PD deficient individuals like nitrofurantoin, sulfonamides and fluoroquinolones. Coming to the drug, these were about the patient factors affecting the antimicrobial choice and the dose. Now coming to the drug factors, it includes spectrum of action, efficacy, pharmacokinetic profile, route of drug, type of infection and cost. Coming to the spectrum of action, for definitive therapy, like in case of syphilis, drug of choice is penicillin. So for definite infection, definite antimicrobial should be used. For empirical therapy, if a patient has come with severe sepsis or severe infection, there to start with, due to unavailability of the sensitivity report, we generally start with a broad spectrum antibiotic. So for empirical therapy, broad spectrum antibiotic is given. Coming to efficacy, the antimicrobial efficacy depend on the drug, depend on its dose, duration and frequency. With bacteriostatic drug, bacteria can start dividing after MIC level falls. Bactericidal drugs are more efficacious than bacteriostatic drug. Coming to pharmacokinetic profile, ciprofloxacin penetrate tissue better, ceftriaxone penetrate blood-brain barrier easily, and hence in meningitis patients ceftriaxone are used. Now, antibiotics can be broadly classified as per the pharmacokinetic profile into two groups. One is concentration dependent killing and another is time dependent killing. Now, what do we mean by these? Basically, in concentration dependent killing, the efficacy of the antimicrobial depend on the concentration of the drug in the blood above the MIC, how much it is. It is irrelevant that the drug, it does not depend on the time factor for how much time it is above MIC, but it's the concentration of drug, that is how much it is above the MIC, that is important. So here they are dependent on the the efficacy of the antimicrobial is dependent on the concentration in the blood above the MIC level. Aminoglycosides, fluoroquinolones and metronidazole are some of the antimicrobials that basically follow concentration dependent killing. Now, that is, they kill bacteria more rapidly if their serum concentration are kept above MIC. It is for this reason gentamicin, which we have previously used in a dose of 80 mg thrice daily, is now preferred to be given once daily, because if we give the drug higher dose of drug 240 mg once a day, then the concentration of the drug in the blood rises well above MIC and the efficacy of the antimicrobial is increased. Again, after the rise, as the concentration of the drug falls sharply, in most of the time the concentration of the drug is below MIC level in the body. That causes lesser side effects, lesser ototoxicity and nephrotoxicity. Coming to the second, time dependent killing. Here the basically antimicrobial efficacy does not depend only on the concentration above MIC, but it is mostly dependent on the time till which it is above MIC. So this time factor is important in time dependent killing. Like beta-lactam antibiotics, like clindamycin, macrolides, they basically follow the time dependent killing principle, and hence beta-lactam antimicrobials are generally given 6 to 8 hourly or 3 to 4 times a day, so that in most of the time the concentration of the drug is above MIC. Route of drug. For milder infections, generally oral route of drug is preferred, but in serious infection, in sepsis patient, we prefer parenteral route of therapy. Aminoglycosides, vancomycin, penicillin and some cephalosporin are given only via the parenteral route. Now, type of infection. Severe acute infection are better cured with bactericidal drug. In immunocompromised patient, we prefer bactericidal drug. Cost. Generally cheaper, effective antimicrobial should be used to decrease the cost burden. Now, coming to organism related factors, we can broadly classify them into three groups. One is if drug sensitivity pattern is known, like if a patient is suffering from tetanus or suffering from syphilis. Now, we know which drug is most effective to treat them. Guess bacterial infection and based on identification of bacteria. So, if drug sensitivity pattern is known, a specific drug should be used. Guess bacterial infection. If the exact bacteria is not known, but as per the clinical experience, we can think of the bacteria which can cause the disease. In that case, as per the knowledge, we treat the bacteria with the antimicrobial. Example, in case of tonsillitis, boil, vaginitis, urethritis. And lastly, based on the identification of bacteria. Say for example, a sepsis patient has been admitted, we send the different culture and sensitivity report. Till the sensitivity report is available, we have to treat the patient as is having severe infection. In that case, we start with a broad spectrum antibiotic. This type of therapy is called empirical therapy. So, one is empirical therapy, where before specific bacteria are identified by sensitivity report, broad spectrum antibiotics are used. What do you mean by broad spectrum antibiotics? They cover both gram positive and gram negative one. Examples basically tetracycline, chloramphenicol, fluoroquinolones and penicillin with gentamicin or cephalosporin with gentamicin. If anaerobes are suspected, we add metronidazole, clindamycin. Definitive therapy. After the empirical antibiotic has been started, we wait for the sensitivity report, and as per the report, we add a specific drug and withdraw the empirical drug. Coming to antimicrobial resistance, basically it is an emerging global issue for concern. It increases medication cost, length of hospitalization and total burden on the healthcare system. Now, to combat this antimicrobial resistance, WHO has classified antimicrobials into three broad groups called AWARE, A for access group of antibiotic, WA for watch group of antibiotic, and RE for reserve group of antibiotics or antimicrobials. Now, coming to access group antibiotics, these are basically antibiotics that have got activity against a wide range of susceptible pathogens and having low resistance. Total 48 antibiotics have been included under this group, of which 19 are there in WHO Essential List of Medicine. Examples: amikacin, amoxicillin, cephadroxil, cefazolin, doxycycline, gentamicin and others. Watch group of antibiotic. These antibiotics basically have higher resistance potential and are the most of the highest priority agent among the critically important antimicrobials. 110 antibiotics have been included in the list, of which 11 are there in WHO Essential List of Medicine. Examples: azithromycin, ceftriaxone, levofloxacin, clarithromycin and others. Reserve group of antibiotics. These have got basically, these are reserved for the treatment of infection due to multi-drug resistant infection. Antibiotics in the reserve group should be treated as last resort, where other antibiotics are not effective. 22 antibiotics are there. Examples: tigecycline, daptomycin, linezolid, polymyxin B, colistin and others. Now, we use antimicrobials. Now, three problems can be there. Number one, overuse of antimicrobials. In many of the cases, multiple antimicrobials are used. Now, this overuse of antimicrobials causes irrational uses, like a person with whom oral antimicrobial can suffice. We use intravenous antibiotics in them, number one. Number two, self-administration of antibiotic in disease or in fever of non-infectious origin. And number three, antibiotics are usually prescribed for viral cough and fever, where antibiotics have got no role. Coming to the second problem, misuse. Antibiotics are commonly misused when broad spectrum antibiotics are given in a drug susceptible organism, where narrow spectrum antimicrobials can be used. Underuse, unavailability of the drug, inadequate dosing and frequency, premature discontinuation of antibiotics. Coming to antibiotic stewardship program. It is a coordinated intervention designed to improve and measure the antibiotic appropriate use of antimicrobial agent by promoting the selection of optimal antimicrobial drug regimen, including dose, duration and frequency and route of administration. Objective: number one, usage of safe and appropriate antibiotic. Number two, reduce the cost burden on the healthcare system due to antibiotics and to reduce the incidence of antimicrobial resistance and to decrease the adverse event with the antimicrobial use. The balance between safe, appropriate antibiotic and broad spectrum antibiotic is essential. Now, various strategies that can meet up to combat the antimicrobial resistance or that can be implemented in antimicrobial stewardship program. Number one, appropriate antimicrobial therapy, rational antimicrobial prophylaxis like in surgical patient, to form a standard treatment guidelines that has to be revised from time to time, to conduct audit, evaluation, feedback, intervention for the rational usage of antibiotics, to implement formulary restriction for pre-authorization and various educational and administrative activities to improve antimicrobial prescription. Now, component of antimicrobial stewardship, we should choose the right antibiotic. 4 Ds basically: right drug, right dose, right dosing interval and right duration. So, choice of correct antimicrobial for the correct duration in correct dose and in correct frequency. Other components being switching of the oral parenteral to oral antimicrobial therapy, streamlining strategies, infection control and appropriate use of microbiological laboratory. Antibiotic cycling. Now what do you mean by it? Basically, it refers to the scheduled withdrawal of antimicrobial and substitution with a specific antimicrobial. Basically, we are here switching from empirical therapy to the specific therapy, aiming to prevent or reverse risk of antimicrobial resistance. Antibiotic use strategies. Now, this antibiotic usage basically can be measured by two methods. Number one is days of therapy, DOT, days of therapy, for how much duration the antibiotic has been used. Number two, DDD, defined daily dose. So basically these are describing the duration of therapy and the dose of the drug. Rational use of DOT and DDD improve patient outcome with lesser adverse effect. Coming to the combination therapy, generally combination antimicrobials are unnecessary, increasing the cost burden, increasing the adverse effect and basically antimicrobial resistance. Some beneficial antimicrobials, combination antimicrobials are: number one, cotrimoxazole, combination of sulfamethoxazole and trimethoprim, combination of penicillin with streptomycin in treatment of the subacute bacterial endocarditis or with gentamicin, rifampicin with isoniazid for the treatment of tuberculosis, and carbenicillin with gentamicin for pseudomonas infection. Now, optimization of dose of the drug and the duration of therapy. It depends on several factors like pharmacokinetic and pharmacodynamic properties of the drug, causative microorganism, site of infection, patient characteristic like age and comorbidities. Generally, for certain infections, the duration of the therapy has been defined or basically set by the different organizations. Like in case of uncomplicated urinary tract infection, we generally prefer to give the antibiotic for 5 days. Acquired pneumonia for 7 days, ventilator associated pneumonia for 8 days, meningococcal meningitis for 7 days, uncomplicated secondary peritonitis for 7 days, uncomplicated soft skin and soft tissue infections for 5 days. Switching from the parenteral to the oral therapy, it depends on several factors like when the patient has been admitted with severe sepsis, we generally prefer to give parenteral antimicrobial therapy. Now, when to switch from parenteral to the oral therapy? Number one, availability of the oral drug, very important. Number two, oral absorption is good. Adequate oral antibiotic is available. Patient is afebrile for the last 24 to 48 hours and there is no sign of sepsis. Monitoring of progress to find out the impact of antimicrobial stewardship and on antimicrobial use and resistance pattern, several programs are conducted which basically evaluate challenges and other unintended consequences of the program or the antimicrobial use. Clinical outcomes should be correlated with the usage of antimicrobial. Coming to the antimicrobial stewardship team, it includes a basically infectious disease specialist, a pharmacist, a microbiologist and the medical directors. Standard treatment guidelines should be published and revised from time to time. It improves patient care in accordance with the current antimicrobial resistant data. Disposal of antibiotics. Now, inappropriate disposal of antibiotics can lead to the basically hazardous effect on the human and the environment. So, the medicine which have been expired should be returned to the pharmacy for safe collection and disposal. by incineration or other methods. If that is a liquid drug, that should be dissolved in the water or diluted with water and should be returned after and should be disposed after 2 weeks.